Okay, let's dive right into this. Welcome to today's Explainer, where we aren't just doing a dry review of medical data, we are looking at a literal, high-stakes race against time. We're mastering cardiac arrest and the Advanced Cardiac Life Support, or ACLS protocols. Every single second absolutely counts when a patient's life is on the line, so let's get right into the science of saving a life.
Look, when we talk about cardiac arrest, we are talking about the absolute, sudden cessation of the heart's mechanical activity. Picture a chaotic, instantaneous collapse. The patient is completely unresponsive. They present with apnea and absolutely no detectable pulse. Arterial blood pressure plummets, and perfusion just instantly stops. Visually, their extremities turn cold and clammy almost immediately, and cyanosis sets in, turning the skin a bluish hue. It is an immediate, catastrophic systemic failure.
But what actually causes this sudden failure? Well, for adults experiencing sudden cardiac death, a staggering 80% of the time, the overwhelming culprit is coronary artery disease. It's a massive vascular event, but contrast this briefly with pediatric patients. Their cardiac arrest usually don't start in the heart. In kids, it typically stems from respiratory failure or progressive shock. So the origin of the crisis is different depending on the patient's age, but the immediate need for intervention, that remains exactly the same.
All right, moving into phase one, the chain of survival, specifically basic life support.
When that collapse happens, the 2010 American Heart Association guidelines tell us that our success relies entirely on swift, decisive action in those frantic first moments. Here are the critical first steps. 1. Determine responsiveness and immediately activate emergency medical services. 2. Check the pulse, but do not waste time. Take a maximum of 10 seconds. 3. If there's no pulse, start CPR with 30 chest compressions at a rate of at least 100 per minute, pushing down at least 2 inches deep. And 4. Deliver 2 rescue breaths. What's really interesting about this is how it completely distills absolute panic into actionable, life-saving science. You don't overthink it. You just follow the steps to keep oxygenated blood moving to the brain.
Next up is phase 2, diagnosing the rhythm, which is essentially the fork in the road. Once advanced help actually arrives with a monitor or an AED, the electrocardiogram forces us to basically choose our own adventure, and that's based entirely on the heart's electrical output. We're looking at one of 2 distinct paths, shockable rhythms versus non-shockable rhythms. Shockable rhythms include ventricular fibrillation, or VF, and pulseless ventricular tachycardia, PVT. This is pure electrical anarchy in the ventricles, resulting in zero cardiac output. On the other side, we have non-shockable rhythms, pulseless electrical activity, PEA, and asystole, the dreaded flatlines. Interestingly, out-of-hospital VF rates are actually declining historically, and that's a bit concerning for emergency providers because patients actually have much higher survival rates with those chaotic, shockable rhythms than they do with the flatlines.
Let's head down path A first, treating shockable rhythms.
To tackle that electrical anarchy of VF and PVT and give the patient the absolute best chance of survival, the non-pharmacologic priority is massive and immediate, an electrical shock. We use 360 joules for a monophasic defibrillator or 120 to 200 joules for a biphasic one. And listen, here is the rule you absolutely cannot break. After you shock, you do not pause to check the pulse. You immediately perform 2 full minutes of uninterrupted CPR. Only after those 5 cycles of compressions and breaths do you analyze the rhythm again.
Now, if the shock and CPR don't break the arrhythmia, we bring in the pharmacological heavy hitters. Epinephrine is our first line, 1 milligram administered via IV or intraosseous injection every 3 to 5 minutes. Vasopressin at 40 units can actually replace the first or second dose of epi, and if the rhythm is still completely unresponsive, we push an antiarrhythmic like amiodarone, starting with a 300 milligram bolus. The crucial point here is that these drugs, specifically epinephrine, they aren't just magical heart starters. They work by improving coronary and cerebral perfusion pressure through vital systemic vasoconstriction. We are literally squeezing the vessels to keep the brain alive during that low-flow state of CPR.
All right, let's switch gears to path B, treating non-shockable rhythms. Let's just clear up a massive Hollywood myth right now. Do not shock asystole. Defibrillating a flatline causes a parasympathetic discharge that can actually reduce the chance of any spontaneous circulation returning. You're doing way more harm than good by shocking here. Furthermore, it's really worth noting that the 2010 AHA guidelines completely removed atropine from this specific algorithm. It's just no longer a part of routine care for asystole or PEA.
Instead of shocking, you have to immediately step into the shoes of a medical detective to rapidly identify and reverse the H's and T's. These are 12 underlying causes. Is it a blood or fluid issue like hypovolemia? Maybe a respiratory problem like hypoxia or attention pneumothorax? Are there metabolic issues like acidosis, hypoglycemia, or a potassium imbalance? Could it be a temperature drop causing hypothermia, or perhaps cardiac or other issues like tamponade, a massive coronary thrombus, or a drug overdose? CPR and epinephrine will absolutely buy you time, but if you don't find and fix the underlying cause from this group, the heart simply will not restart.
Finally, Phase 5, post-resuscitative care, stabilizing the system.
Let's take a collective breath here. We did it. We've achieved ROSC. The pulse is back. But surviving the arrest is really just the first hurdle. Now we have to manage post-cardiac arrest syndrome. To preserve the brain and lungs, we raise the head of the bed to 30 degrees to reduce cerebral edema and the risk of ventilator-associated pneumonia. We carefully titrate the oxygen fraction down as tolerated. We use waveform capnography to target an end-tidal CO2 of 40 to 45 millimeters of mercury. And this brilliantly illustrates a vital concept in post-arrest care. Overventilation and oxygen toxicity can actually be just as dangerous to the recovering brain as the cardiac arrest itself. More oxygen is definitely not always better once the pulse returns.
Finally, we deploy what I think is one of the most fascinating protective measures in all of modern medicine: therapeutic hypothermia. For unconscious adults who achieved ROSC after an out-of-hospital VF arrest, we deliberately cool the patient down to between 32 and 34 degrees Celsius, or roughly 90 to 93 degrees Fahrenheit. We maintain this targeted cooling for 12 to 24 hours. Why? Well, because this profound cooling suppresses damaging chemical reactions in the brain after blood flow is finally restored. It is literal brain preservation. I should note, however, that current guidelines indicate there's insufficient evidence to recommend therapeutic hypothermia for pediatric patients just yet.
So, we've covered a tremendous amount of ground today. We know the algorithm inside and out. We know the exact drug dosages, the joules for the defibrillator, and the critical reversible causes to hunt for. But all of this incredible science relies entirely on action. When the clock starts ticking and someone collapses right in front of you, are you prepared to be the first link in the chain of survival? Because that first link is what makes everything else possible. Thanks so much for joining me on this deep dive, and I'll catch you on the next explainer.